Hi everyone, continuing with our H's and T's series, in this video we're going to review the cardiac tamponade. Now, the cardiac tamponade kind of comes in two flavors, acute and subacute. And to kind of understand these better, we first have to review the anatomy of the pericardial sac. Starting from the outside is the fibrous layer. This is a tough layer of the pericardial sac. Moving inward, we have two more layers, the parietal layer and the visceral layer. The visceral layer being closest to the heart. Now, in between the parietal and visceral layer, that's where the pericardial fluid is. And there's usually right around 50 cc's of fluid in the pericardial sac. And this fluid acts as a lubricant, so the heart can beat without rubbing itself raw. So that's the structure of the pericardial sac. Now, acute means quickly, happens very, very quickly. And most acute cardiac tamponades are associated with trauma, blunt force trauma to the chest. And in this case, what's happened is the heart has been lacerated and it's bleeding. So it's bleeding from the heart and it's starting to fill that pericardial sac up with blood. And as it does this, it literally begins to constrict the heart. Because the pericardial sac, although it will stretch, it doesn't stretch very quickly. So in this acute setting of blood bleeding into the sac from blunt force trauma, it constricts the heart and prevents the heart from filling up during diastole. So it's almost a diastolic failure. Okay, so the treatment for this acute cardiac tamponade, relieve the blood. You got to get the blood out of the pericardial sac. This can be done by the physician in the emergency department, and really it's a needle stick. They're just going to go in with a needle, they're going to tap that pericardial sac, and they're going to remove that fluid. One of our jobs in the field is to recognize an acute cardiac tamponade. And there's three big symptoms that we associate with this. One, muffled heart tones. Now, how do you tell muffled heart tones? That means you know what regular heart tones sound like. So it's imperative that we're listening to heart tones all the time so we can tell the difference between a normal lub-dub and a muffled lub-dub. Next, hypotension. Yeah, the pressure is going to drop. Why? Because the blood can't get back into the heart. And then lastly is JVD, jugular vein distension. And again, it's because the blood cannot load into the heart, so it backs up into the venous system a little bit. Those three symptoms, muffled heart tones, hypotension, and JVD, make up Beck's Triad. And that's an easy way to remember the symptoms of a cardiac tamponade, Beck's Triad. Now, that's the acute pericardial tamponade. Let's look at the subacute pericardial tamponade. There's a couple of ways that this can happen. It can happen, again, with bleeding directly from the heart. And this can happen not during a CABG because they open the pericardial sac, but during, say, we took the patient to the cath lab. And let's say there were some microlacerations that may have occurred to the vessel that are slowly leaking. And this happens. Some studies say it can happen up to 0.1 to 0.6% of the time. The AHA hasn't published anything that I'm aware of in the textbooks for a number of incidents of this, but this can happen. And there's also kind of a recommendation that we could tell this, we could find it by doing an echocardiogram 24 a week, 2 weeks after they've gone to the cath lab, so we can detect this. Another cause of subacute cardiac tamponade occurs with the pleural effusion. And in this case, the heart isn't bleeding, that isn't the problem. The problem is there's an increased amount of fluid, pericardial fluid, in between those two layers. And this usually happens or is associated with pericarditis. So it's an infection of the heart that led to an increased amount of fluid within the pericardial sac. In between the parietal and the visceral layers, this fluid starts to build up secondary to an infection. And I've heard of people tapping and taking out almost 2 liters of fluid from this. If you look at these chest x-rays here, you can see that is a huge heart on the x-ray. If we look at CT, we can very clearly see the pericardial sac filling with fluid. So again, remember, in ACLS, our job is to detect this. Okay, so how do we treat the acute symptoms of a cardiac tamponade in the field? One train of thought is rapid, aggressive fluid infusion. 0.9, start dumping 0.9 into them. And the thinking is we're trying to keep more fluid inside the ventricles than what's leaking outside the heart, compressing it. It's a temporizing measure only, and hopefully it'll buy you some time so you can beat feet to the ER. I'm Mark, thanks for watching, I'll see you in the next video.